Welcome, everybody, this evening. I'm so excited to have all of you here with us. We are excited to have Dr. Jacqueline Smeaton present this evening on functional fertility medicine approach. We're also very excited at the A4M to be working with Dr. Smeaton as we launch our new fertility certification course, which will be held in person on September 29th through October 1st in Chicago. So let me give a quick introduction on Dr. Smeaton. Dr. Smeaton is one of the country's top leaders in functional and integrative approaches to infertility. For 15 years, she has been helping couples build their families, even when there was no hope. She works with individuals on proactive fertility preparation, as well as with couples with infertility of almost all forms and causes. Her specialties are working with women to improve their egg quality, as well as helping couples with unexplained infertility. She loves to work with couples on natural conception, as well as through supporting IVF. In addition to seeing clients, Dr. Jacqueline does extensive teaching, training other physicians how they can improve their success rates with patients. In addition to reproductive medicine, Dr. Smeaton has a diverse career spanning dietary supplements, health technology, and innovation and strategic leadership and commercial strategy in the integrative medicine industry. She has served on the faculty at Bastyr University as president of both the New Hampshire Association of Naturopathic Doctors and the American Association of Naturopathic Physicians, as well as a board member of the Integrative Health Policy Consortium, the American Herbal Products Association, and several others. So I'm going to turn it over to Dr. Smeaton.
Thanks, Amy. And thanks to all of you for coming tonight. I get very excited when I get to share this approach to fertility with healthcare practitioners like yourselves. I'm guessing that some of you probably have a fertility background and are maybe looking to add a more integrative style or approach. Others of you may be in more of a general practice or an integrative medicine, functional medicine style practice, anti-aging practice, and wanting to do more for your fertility patients. So all of you are going to be really well served tonight. And I think that you're probably going to get a pretty good taste of the approach to care that you might think about taking with fertility patients and clients, and some of my favorite protocols and products that you can think about using for the things that I see most commonly. But you need more time to get into all of this in depth. And so I am so excited, and thanks to Amy and Liz and Doreen and the whole team at A4M for their interest in building out a fertility certification so we can get more practitioners doing this kind of work. Because as you'll see as we go through the webinar tonight, the foundational things that you think about when you think about anti-aging medicine, regenerative medicine, they absolutely apply to fertility. In fact, just a couple of weeks ago, I gave a presentation on fertility as the canary in the coal mine. And really, there's a lot of data showing that infertility is actually one of the first signs of chronic disease. This is particularly in men, things like metabolic syndrome, type 2 diabetes, cardiovascular dysfunction, even things like autoimmune disease oftentimes show up as infertility first. So it's kind of earlier on in the path that delicate reproductive system gets affected. And so if you're working with patients on this, you're actually doing true preventive medicine for them and for their future children. So let's go ahead and dive in. So what we're going to cover tonight, just a little introduction to infertility. I do want to walk you through kind of what standard workup is. Oftentimes patients will come to you having already had this done, but if not, this is what you're going to want to do. That first visit, the first lab workup. And then I want to talk to you about some of the things that I see most commonly in that kind of integrative fertility world. So we're going to talk about anovulation and menstrual disorders, but then we're really going to focus on egg and sperm quality, which is an area where really fertility care really shines. And then we'll talk about the functional approaches to infertility and what some of those key fertility drivers are that you need to be thinking about from a functional point of view. And then lastly, we'll share a bit about the upcoming certification. So I'm sorry, this chart got a little bit cut off here, but this is older data. This is actually published in 2005 but the statistics are just as scary. If you look at infertility rates for women, they've been going up. And now it's about 1 in 8 couples that are having trouble conceiving. So to put that in perspective, that's about the same prevalence of breast cancer in this country. And so we talk a lot about breast cancer, but fertility has been almost like in a little black box until probably about 5 years ago, where people have started to share their journeys and there's been a little bit less stigma. And that's made it a lot easier for people to come forward and get help. But there is a thought that this is because women are trying to conceive when they're older. And it is true. So this, like I said, this is older data, and I'm sorry that it's cut off, but this blue line is age 35 to 44. The red line is 25 to 34, and the black line is 15 to 24. So you can see that infertility rates are highest in women who are over 35. However, the trend lines actually don't differ all that much. We're seeing rising rates of infertility in women across the board, regardless of age group. And actually, the same is true for men. The rate of decline in sperm parameters has been about 1% per decade, which has been compounding. And actually, now the rate of abnormals has been increasing. So we think a lot of that is due to environmental factors. We'll talk a bit more about that later on. But just rolling it back, the first time someone comes in to see you for fertility, you really want to do a complete fertility history, good medical history, including menstrual history, sexual history. We won't get into it much today, but we will do a whole session on it at the seminar on the reproductive microbiome. And we now know that, cutting to the chase, the uterus is not a sterile environment. There's actually probiotic microorganisms that live in there and promote healthy fertility. And if someone has a history of sexually transmitted infection, then that can linger, much like many other viruses and bacterial infections, and disrupt the microbiome, and that can lead to problems with implantation. So sexual history can be real important to know about infections, how many partners they might have been exposed to, et cetera. Family history, medications and supplements. We talk a lot about lifestyle and social habits, and occupational history, diet, sleep, stress level, everything like that. And then you want to do a complete review of systems as well. And we'll talk a little bit about why. Now, when it comes to physical exam, you really want to take a look at someone's overall physical health. What's their weight? Do they have properly developed secondary sex characteristics, et cetera? I always also take extra care to make sure that the thyroid looks really healthy, and you can test it on labs as well. And then if you're doing pelvic exams, you'd want to make sure that there's no lesions, no abnormal discharge, the cervix is within normal limits, and that the uterus and the ovaries are palpated with no masses, no abnormal pain to palpation. Really making sure you're not dealing with fibroids, endometriosis, or any kind of masses. Now, I love to work with women to help them understand their hormones through cycle tracking first. And I'll make sure some of these resources become available to you guys. Really, cycle tracking can give you so much information on hormone status. And what's nice is it's cycle to cycle, and it's throughout the entire cycle. It's not just a single serum time point. So this can really give you, an idea of what's happening hormonally for a woman throughout her menstrual cycle. You also can see a little bit about the fertile mucus that she's making or not making, which tells you about the hormone estrogen and also tells you about how her body is getting ready for ovulation. You also can help couples optimize timing of conception, because with cycle tracking, which involves that basal body temperature plus monitoring mucus, you actually can start to see changes that tell you the beginning of the fertile window each month. And then you'll see a temperature shift on the oral temperature, which tells you the end of the fertile window. So you can help couples really optimize their timing by taking a look at these cycles every month and teaching women to utilize that as a tool. You also can pick up pregnancies, possible miscarriages, and a lot of hormonal imbalances through cycle tracking. So I really like doing that. It's free. Well, not free. It costs $10 to $12 for a basal body temperature thermometer. There's many, many apps there on the market that you can download that will track. Now there's even thermometers that sync with apps so that the woman doesn't even have to input any data. And then there's wearable devices now too, of course. I use an Oura Ring, which I have here, which in the second generation, they started cycle tracking. And I just got a notification today, actually, that they're partnered with another app for more in-depth analysis of your cycle if you're wearing that, because of course that monitors your temperature. The Apple Watch can do it. Fitbits can do it. There's a special bracelet called an Ava that has some clinical trials on it. So lots happening in this area to give women that feedback. Okay. So then what labs might you initially run? Generally, I run like what we call the prenatal panel, which is a screen for all of the infections that can cross the placenta, plus basic blood work, CBC, blood typing. I always look at TSH. Well, a more expanded thyroid panel I'll typically run. And I used to do reflex antibodies, but now I actually add antibodies for everyone because there's data showing that if there's elevated thyroid peroxidase antibody, even in a euthyroid patient, that can still lead to infertility due to autoimmune connections there. Metabolic panel, I'll skip the bottom there, ferritin, vitamin D, vitamin B12, and homocysteine. So kind of some screening for nutritional absorption, for inflammation, things like that. And then you can see in that hormone section, we generally want to check on cycle day 3, estrogen, follicle stimulating hormone, and anti-Mullerian hormone. And together, these can serve as a way to evaluate ovarian reserve or egg quality. It can sometimes be called as well. Then it's written on here as day 21, but it's really 7 days post-ovulation. So it's day 21 for a 28-day menstrual cycle. You want to check progesterone levels, and that would be catching the peak of progesterone. And then if it's indicated due to patient's symptom picture or maybe irregular cycles, you might add prolactin, testosterone free and total, DHEA sulfate, LH, et cetera. Okay. And then also part of the routine screening, I don't do it myself as a naturopathic physician, but a reproductive endo would or an OBGYN. A hysterosalpingogram is considered kind of a standard as part of that basic workup. And that is when they put a dye into the uterus, and then they're able to watch to see if that dye spills into the abdominal cavity. So that would tell you that the fallopian tubes are patent or open. And so obviously, if there's blocked tubes or some kind of mechanical blockage, normally what would be recommended would be IVF, because otherwise there'd be no way for egg and sperm to meet or for a fertilized egg to kind of make its way into the uterus. So when it comes to that hormonal evaluation, like I said, those day 3 labs are really helpful to take a look at ovarian reserve. Generally, what you want to see is estradiol below 50 and follicle stimulating hormone below 10. And so below 6 is really optimal for FSH, but you don't usually see that in women that are in their 20s. And estradiol, you really want to see like that 30 to 50 range. When estradiol is up over 50 or FSH is over 10, that can be indicative that the ovaries are not as responsive. Okay. Anti-Mullerian hormone, they have age-dependent ranges. So you'd want to take a look at the range specific for your patient. But generally, optimal is greater than 4. But that's really, you're only going to see that in much younger women. Women who are in their mid to late 30s and 40s, generally, if you can get an AMH of 1, that could be great. But I've seen women also get pregnant with an AMH of 0.1. So you have to put it in perspective. It's kind of a hotly debated lab analyte that has questionable significance when it comes to whether women can conceive naturally or conceive with IVF. But looking at ovarian reserve is kind of a fuzzy picture anyway. So I do like to still order it to give me as much information as possible. Other things that you can do if you're questioning that is order something called an antral follicle count, which is looking at how many follicles are developing early in the cycle. That's done through ultrasound, or a Clomid challenge or a clomiphene challenge. So there are other things that can be done, but this is like a good basic evaluation. Now, when it comes to day 21 progesterone, you really want to look at 2 things. One is, did they ovulate that cycle? A serum level greater than 6 or 10 will indicate ovulation's taken place. But a mid-luteal progesterone over 10 and actually over 15 is even better, is better associated with a better per cycle pregnancy rate. So generally, I'm shooting for progesterone like 15 to 20 range. Interestingly, I do find a lot of practitioners really give progesterone very, very frequently. Because it's like, well, more is better. But I was looking into data on this, on like what the optimal range is. And there are studies showing that when women have a serum mid-luteal progesterone over 41, actually the success rates for implantation and IVF and transfers really starts to decline. So you can have too much of a good thing. So I wouldn't just blanketly supplement progesterone. I think I see a lot of practitioners doing that, and not a great idea. And then we've talked about some of these other kind of health status labs that you might run first go. So that'll give you a first overview. And for a female, you're really wanting to assess egg quality, particularly if your patient's over 35. I didn't put it on this list, but also you'd be wanting to run a semen analysis for a male partner. Don't forget to do that. You don't want to learn through experience that you find a problem with the female partner, you spend 3 to 4 months working on it, they still don't get pregnant, and then you finally test the male and realize he had an issue too, because you've lost months and months of time with that. So make sure you work up both partners at the beginning and don't assume that, things are going to be fine. Okay. So let's talk briefly about just anovulation and menstrual disorders. Again, this is like many hours of gynecology training put into 3 slides. But the things that I see most often in my kind of functional oriented practice are amenorrhea, women who don't cycle. And that would either be primary, like they've never cycled, or more commonly secondary, where they've just stopped cycling, or oligomenorrhea, where they have really, really long cycles. I see both of those things really commonly. One of the biggest reasons for both is actually PCOS. That's the most common irregularity, menstrual irregularity. It's about 10% of women that have PCOS. Then we also see a lot of premature ovarian failure or insufficiency. There's different terminology out there. And this would be things like your perimenopausal or menopausal patients. And I do see a lot of patients in my practice who are between 40 and 45. So it's not uncommon that they start to see some menstrual irregularity. And when we evaluate them, their FSH is 100 or quite elevated, indicating that they're kind of moving along into perimenopause. So there's things that can be done in some instances to help kind of rejuvenate the ovaries. And also with perimenopause, one hallmark of it is that some cycles are normal and you'll ovulate, and other cycles are not and you won't ovulate. So it is believed in the fertility world that women can get pregnant in perimenopause if you get a good egg and you get, a cycle where ovulation occurs. But there's a lot of challenges in working with older women. We'll chat about that. And then the last one is short luteal phase. A short luteal phase is when the time between ovulation and the period, the menses beginning, is shorter than about 12 days. And ultimately, once ovulation happens in the ovary, it's actually about a 7-day journey for that egg to leave the ovary, go through the fallopian tube, get fertilized, make its way to the uterus, and implant. And now, if we think about the menstrual cycle, apart from pregnancy, the start of the menses is actually about 5 days before the bleed. That's when deciduization happens, which is kind of I always think about it like the steel doors of a warehouse kind of coming to close, and it closes off around the lining of the endometrium to prevent implantation. And then there's also a lot of cytokines and chemokines that get released that have to cause a lot of physiological changes that precede bleeding, cutting off the blood supply, waiting for that tissue to undergo necrosis and slough off. So you have 7 days from ovulation. So let's say day 14, you ovulate. You have until about day 21. And then 5 days before, that only leaves a window of about 2 days for implantation to happen if the luteal phase is 14 days. So if it's shorter than that, 12 days, 11 days, 10 days, those time starts to overlap. And by the time a fertilized embryo gets to the uterus, it's too late because the uterus and the endometrium have already started to move towards menstruation. So that's oftentimes due to improper release of progesterone, and we can help to kind of lengthen that luteal phase. But I do catch it a lot, even in couples who've been worked up. And it's in the published literature, but I've also seen publications that say it doesn't exist. But in my experience, it definitely does exist. So what are the conventional approaches when there's menstrual imbalances? Either hormone management through IVF, injectable gonadotropins, or induction of ovulation with medications. Usually it's clomiphene citrate, which is an anti-estrogen drug. And it does have a good success rate, about 70 to 95% in triggering ovulation in women. So it can be effective. There are also a lot of great integrative approaches, and we'll dive into this a little bit more. There's not a lot of research on herbs, but I use herbs all the time to support the HPO, hypothalamic pituitary ovarian axis. Vitex is one of my favorites. So if you're wanting to think about using herbs for women's hormonal systems more, Vitex or chaste tree berry is a great one to kind of dive into the research on first. I also use a lot of biphasic tinctures. This would be two combinations of herbs, one that's more estrogen supportive that you'd use the first half of the cycle, and another that's more progesterone supportive in the second half of the cycle. And that can really be helpful to help women's cycles regulate and get them ovulating as well. Can you use hormones? You can. But as a naturopathic doctor, I have a strong love of herbal medicine and find this to be really effective for women. The other thing that I want to talk about is a hypothalamic pituitary insufficiency. So when we talk about like perimenopause or the ovarian insufficiency, what you see on labs there is that the LH and FSH in particular would be very, very high, but the ovaries are not producing estrogen and eggs, follicles in response. Another thing that you can see that looks the same and ovulation, but when you run labs, LH and FSH will be very low. And what that is basically the brain's communication to the ovaries has stopped. Okay, so instead of the brain shouting at the ovaries and the ovaries not responding, the brain has like stopped telling them what to do effectively. And generally, this is caused by stress, even in conventional literature and textbooks. Things like weight loss or insufficient caloric intake, strenuous exercise, or even emotional stress can cause the cycles to stop. Okay. So when this happens, generally I would want to do an adrenal, HPA axis evaluation workup. And I think about things like nervines and adaptogenic herbs to help address the stress, nutritional counseling to help a patient achieve proper weight. And I mentioned PCOS as the most common cause of oligomenorrhea. In this case, we will talk more about PCOS also, but you have to think about improving the stress response, HPA function, also hormonal regulation, and then finally blood sugar regulation and kind of metabolic support. So PCOS is multifactorial, but really integrative medicine approaches are so effective when it comes to PCOS that we have really great success rates in this patient population. Okay, let's talk about egg and sperm quality. So we're going to kind of talk about these both together, and you'll see why in a minute. So when it comes to ovaries, you'll hear a lot about diminished ovarian reserve, where a woman's ovaries are not producing eggs like they used to. Okay, this can be due to things like exposure to chemotherapy. Now, at least we're smart enough to counsel women on fertility before they undergo chemotherapy. So if a woman in her 20s got cancer, she would be counseled to freeze her eggs before she went through chemotherapy so that she would have unaffected eggs. But pelvic irradiation, there's certain genetic abnormalities that can lead to the ovaries kind of diminishing their reserve more quickly. And then a lot of lifestyle factors like smoking, environment, exposure. These are again, tough to tease out because humans live complicated lives. We know that these things that cause high oxidative stress damage the ovarian tissue. And then aging is another one. And it's not deniable. Aging does change the ovarian reserve, but for different women, it happens at different rates. Now let's talk briefly about sperm quality. So there's lots of different aspects of sperm quality. You can have low volume of semen, low concentration or low count. And there's two kind of ways that this is described. Azoospermia is like no sperm in the sample. Oligospermia is low sperm in the sample. So you'll see both with patients. More commonly, you'll see oligospermia, and that's one that we can make humongous improvements when it comes to functional medicine. Poor motility, poor morphology, leukocytospermia, which is white blood cells in semen, and then there's other less common abnormalities as well. Now, there's a lot of reasons why sperm quality declines as well. One of the biggest is oxidative stress. Oxidative stress changes the fluidity and permeability of cell membranes. And for sperm, it changes their functional competence, their ability to swim and move their tail and swim in a straight line. And most affected is actually the acrosome reaction, which is the enzyme reaction that happens when sperm fuses with the wall of an egg in order to be able to kind of penetrate it there. And when we look at sperm quality, we do see relationships between the semen quality, and things like the amount of glutathione in the semen or superoxide dismutase activity and catalase activity. So the body's ability to quench free radicals really influences the health of sperm. And when it comes to like the research body, most of the time we understand things in sperm first, and then you'll see data move into like females. Because I think it's so easy to collect sperm samples, semen samples, and be able to like manipulate them in an ex vivo environment, where eggs are a little bit trickier and ovaries are a little trickier to like really, hone in and do like very good specific research. So when we look at sperm quality, there's like several leading theories here. And I'm sorry, I forgot to update this granulosa cells. Testes don't have granulosa cells. That's an ovary. Till I made the ovarian slide first. But a couple of things impact sperm quality. You have naturally declining androgens, which can happen with aging. You have changes to the mitochondria that they don't function as well. And then you have basically dysfunctional testicular cells. And both due to oxidative stress and then carbonyl stress. And carbonyl stress is like when you take oxidative stress and then you add a lot of sugar in the environment. And actually, carbonyl stress causes permanent changes to proteins and enzymes that cannot be undone. And it's really very harmful. So that's why glycemic load is so important for fertility, making sure patients are eating like a low glycemic diet. And with sperm quality, actually, when they're made, they actually are stored in the epididymis for about 3 months before they're ejaculated. That's where they mature. And more often, the sperm issues arise from damage during that 3-month wait period versus like as a true manufacturing error or issue. Now, when we look at the oocyte, it's actually really similar kind of theories to what causes the quality to decline. The only thing that eggs have going against them as well is that the cells of the ovary have telomeres that shorten. The germ cells in the testes don't. They actually express telomerase and so can preserve a lot longer. So that's why men like Mick Jagger can have babies well into their 70s, where females don't have that opportunity. Now, I'm sorry, somehow the citation dropped off this page, and you're going to see this over and over again. This actually was published in 2017 in Oncotarget journal. And it was an article on unexplained infertility. And I loved this diagram because really, I think this could be replaced with just the word infertility in red. But when we think about what leads to infertility, you have to think about egg quality. You have to think about sperm quality. You have to think about the health of the embryo. So like the DNA inside the egg and the sperm. You have to have an endometrium that's healthy, which when you think about that, you're thinking about blood flow to the endometrium, the hormonal ability to build up that thick endometrium. And then where it says implantation failure, what goes into that is like chronic inflammation, autoimmune, small autoimmune reactions, improper blood flow. So when we think about all those things that need to happen to get pregnant, and then we think, okay, well, what leads to good sperm and egg quality? What leads to a healthy endometrium? And you can see how they kind of work their way up as far as what some of these driving factors are for infertility. And this type of diagram makes a lot of sense to me from an integrative and functional medicine perspective, because we can overlay a lot of the things that we look at for health in general and really realize how they fit into this fertility picture. So I want to spend some time talking about those underlying functional factors that are really critical for fertility. First, inflammation and immune function has to be balanced. If you're really inflamed, it can cause a lot of problems. Cell quality has to be sufficient. That's egg quality and sperm quality. That's like a single bullet on this line, but it is massive when it comes to what we do to help people. You have to have balanced hormones. You have to have good blood flow. And then lastly, the embryo has to be healthy. So you have to have good DNA integrity. And then when we look at what underlying factors lead to all of those other things, we have to look deeper. We have to look at environmental exposures and detox. We have to look at gut health. We have to look at stress and the HPA axis function. We have to look at a patient's nutrition, their immune balance or their state of inflammation, their mitochondrial health, and they have to have low oxidative stress. Those last two are really intertwined, oxidative stress and mitochondrial function. So we think about those when we're treating it as like kind of brother and sister. They both need to be addressed. So let's talk about a few of these. So when we look at environmental toxins, you might have a different opinion when you look at this, but I see very obvious connections with so many aspects of fertility, causing inflammation, altering cellular communication, of course, affecting hormones, because many environmental toxins are estrogen-like in the body, directly causing oxidative stress and damage to sperm and egg. Just a couple of examples of studies, and there are hundreds of studies out there on environmental toxins and fertility. One of them, the biggest really toxin that we have data on, is bisphenol A, or BPA. So BPA concentration was associated with implantation failure in 147 women undergoing 180 IVF cycles. And what they found was that the quartile of women with the highest urinary BPA had 2.11 times the odds of implantation failure compared to the lowest quartile. So we know that it's causing harm there. There's also studies on male health. And believe it or not, the first human study on BPA and fertility wasn't published until 2010. So like not that long ago. This was a 5-year-long study in about 500 Chinese men. And men with higher exposure to BPA, as measured in urine, had lower quality sperm, lower concentration, lower count, poor motility, poor morphology. And the men with that had that effect had levels of exposure equal to what's common in the general US population, if you look at NHANES data. So this type of thing is affecting all of us right now. This is a summary of BPA and male reproduction in an animal model, but you can see some of the studies here have shown impacts on anatomy, hormones, and semen quality. And that's when the animals are exposed as fetuses during puberty and then during their adult life. So I think all we can affect, obviously, is adult life, but a lot of our patients are probably being impacted by what happened when they were in utero, or for boys, what happened during puberty. That's a real important time for epigenetic imprinting, because that's when the testes start to mature. So exposure, it's really scary to think about it. I have 3 boys that are like 10, 13, and 14. And to think about like the health of their children being dependent upon the decisions that they make today, and they're kids of naturopaths, so I can at least control what they do at home. But the future of the world should be concerned if we're putting all of our trust in boys of that age range. So when it comes to environmental medicine, like one thing I think about is like functional lab testing can get so expensive, and using environmental testing as a screening tool feels impractical for a lot of my patients due to cost, the time to process, the risk of finding lots, and not knowing what's actually truly having an impact. So when it comes to screening for functional labs, we're going to talk about these throughout the rest of the presentation. I always start with my intake. Okay. So when it comes to environment, I want to know like what are their hobbies and their occupational exposures. I had one woman who was a potter, and a high school art teacher who were constantly exposed to heavy metals through glazes and things like that. Or patients that live in a really old or a really new house. Old because you could have lead, you could have asbestos, you could have mold, and new because you have all this off-gassing. What's their dietary intake? Do they eat organic or not? What could their pesticide load be? What types of products do they use for cleaning, for their skincare, et cetera? And then I always think about what else can you do besides these functional medicine tests. So a couple of good options for you would be a questionnaire, a functional questionnaire. And I have an example of that in a future slide. And also Dr. Joe Pizzorno has done extensive work in the last decade or more, 2 decades probably of his career on environmental toxins. And he's got a real nice summary in one of his books called The Toxin Solution. And it's back in the appendix. And it's actually completely research-based about utilizing very standard labs like CBC, CMP, et cetera. And within the normal range, even if your patient's within the normal range, different results can indicate a higher likelihood of toxicity with various chemicals. That's a great one because you can run all those tests for about $30 in serum and then put them on this scoring sheet and get an understanding of their risk profile. And cut to the chase, GGT is the real rock star there with like very strong correlation with toxic exposures. So it's so important because toxins can affect fertility in so many ways. It affects sperm health, egg health, inflammation, hormone levels, and so much more. And also, I like to work with patients if they have a lot of exposures, because cleaning up their environment will ensure healthier DNA, better epigenetic expression in egg and sperm. And then for the female, also that she's not exposing that baby to as many chemicals, like you've taught her how to live more clean. So this is kind of a soapbox issue. We could talk about this for a long time. So this is that toxin risk screening tool, which this is kind of a chart that I've made and adapted from the Toxin Solution, but I'd recommend reading his book. It's written for consumers. So it's very science-based, but still comprehensible and really, I think, just life-changing. His big thing is not fertility. It's really more about chronic disease and metabolic health. Those are the biggest impacts, but super, super interesting. And you could use like a toxin exposure questionnaire. This is one that I've used in my practice, that you have the patient look through the different exposures, they check the box of their response, and then you can tally it up at the end to get a score. So some of my favorite kind of basic detox nutrients are here. The first is avoidance. You have to work on avoidance. And after that, vitamin C, fiber, probiotics are great. You want to make sure that gut's functioning. And then you can think about some targeted detox support. And if you're working with fertility patients, you might think about detox support that's also anti-inflammatory. So lots of curcumin, green tea, and then you'll see things that are antioxidants in here too, like grapeseed extract and quercetin, things like that. Okay, next I want to talk a bit about gut health. So again, gut health is something where if the gut's not functioning optimally, you can have impacts across so many different aspects that touch fertility, or physiological changes that touch fertility. GI function can contribute to inflammation, oxidative stress. It can affect hormone levels. It can affect microbiome health. And we do know that there's a connection between the gut microbiome and the reproductive microbiome as well. So you could think about looking at markers like indican and zonulin to look at integrity of the gut. Indican is a marker that will be elevated if there's dysbiosis. It's kind of general, but those might lead you to a broader GI panel or a microbiome assessment. Now, this was published actually January of this year. This was one of the first ones I've seen that looked at gut microbiota and sperm health. And this was a small study, 21 patients who had azoospermia. So they were not making any sperm, not obstructive. So it wasn't due to a blockage in the vas. And then 30 healthy subjects. And they did shotgun metagenomic sequencing and a clinical assessment. And they found unique microbiome patterns in the healthy men and the men with azoospermia. The azoospermia group showed more abundance of a lot of different microbial strains, and those strains suppressed carbohydrate metabolism and enhanced methane production and amino acid metabolism. So we know that microbiome is so important, but this is one of the first studies I've seen that looks at kind of the how and why it would affect sperm. And there's been numerous studies showing a connection between female fertility and the microbiome. You've got connections like the estrobolome, how there are certain microbiota that assist with or impair metabolism of estrogen, so it can change hormonal function. It's also important in order to absorb food properly. In order to get all the nutrients out of your food, you need a healthy microbiome. We know it supports balanced immunity. So dysbiosis is a precursor for autoimmunity, and there's a lot of autoimmunity and fertility now. And we know that there's a connection between the oral microbiome, the gut microbiome, the reproductive microbiome. All of these are connected. So looking at microbiota is a really important piece of the fertility workup kind of in modern day. Okay, next I want to talk about stress and adrenal dysfunction. And again, like you might even have different opinions of all the different areas that this could touch upon, but really stress can be super impacted. Now, when the HPA axis gets activated by stress, it actually inhibits female reproductive function. And this makes sense when you think about evolution, to throw our cycles off and make it harder to conceive when we're under stress, because carrying a baby is a humongous, load for the body to carry. So you want to be in a good, safe, healthy environment for that to happen. But we do know a lot about kind of how and why. So one is that glucocorticoids actually directly inhibit LH and actually directly inhibit the ovaries from producing estrogen and progesterone. And these changes can contribute to hypothalamic amenorrhea of stress in extreme cases. I talked about that, but this does happen on a spectrum. So you'll see menstrual irregularity during times of stress as well. Now, also when activated by stress, the HPA axis can inhibit reproductive function through corticotropin releasing factor. This will actually inhibit the hypothalamus from releasing gonadotropin releasing hormone. Now, there's also CRH receptors in most female reproductive tissues, in the ovary, in the uterus, in the placenta, and in the reproductive system. Corticotropin releasing hormone has inflammatory activity, which can influence ovulation, luteinization, which is like making the corpus luteum, prepping the lining of the endometrium, implantation, and early maternal tolerance. So it's really important to have balanced stress levels. It's not just about progesterone. You'll notice I did not say pregnenolone steal in these slides because the pregnenolone steal is not a real thing, but the impact of stress on fertility absolutely is. So how do you assess stress? I usually do a very thorough history taking. I like to try to understand what their acute stressors are, prolonged stressors, also understanding their history of anxiety and depression. And then last but not least, anyone who's coming to you for help with fertility probably is at least experiencing the stress of infertility. So keep that in mind because it is one of the top stressors affecting couples today. So in this case, I'll generally run like salivary cortisol or an adrenal stress index, 4-point cortisol. I like to do the CAR, which is why I like saliva, but you can also do urine assessment for cortisol, and then just providing support for that HPA axis as required. And I did want to leave you with just some of my favorite stress managing adaptogens. I've used all of these in patients trying to conceive. Shilajit and Siberian ginseng, I save more for males, but all the others can be used in males and females. And I would say that the ones at the top, ashwagandha, chaga, holy basil, and maybe reishi and shatavari are my favorites that I'm using most in my own practice with fertility patients. For nutrition, I'm not going to talk too much about today because I think this is probably one that most of you have been exposed to if you've done like preconception preparation, but definitely want to make sure you talk about nutrition. And then immune balance, autoimmunity, and inflammation can be important to make sure that you're evaluating from that kind of total body functional perspective. Now, immune balance is really crucial for fertility because it affects hormone levels, it affects our ability to detoxify. Most importantly, it affects our immune reaction. Now, remember, implantation is foreign tissue because it's half of sperm's DNA in that tissue. So when it implants, there are really exquisite mechanisms that the blastocyst undergoes to create tolerance by the mom. And so when that implantation happens, if mom's immune system is overreactive, it can really make it tougher for implantation to be successful. Now, when you look at functional medicine tests, like this is an area where inflammation can be tough to like pin down. You can look at things like high sensitivity CRP. That's one of my favorite. Sedimentation rate, which I don't really find to be very, delicate. It would only pick up inflammation on a grand scale. But there are also a lot of small changes that you'll see on like other functional tests, like upregulated aromatase enzyme, if you're looking at metabolites or, looking at different cortisol clearance rates or higher levels of free cortisol. On OAT test, you can see several markers. So things that I wanted to just leave these here with you. I'm not going to go through them in depth, but you'll have this as a reference for some of the patterns that you might see on more functional testing when it comes to like identifying patients that look like they might be chronically inflamed. Okay, and we've talked about oxidative stress and mitochondrial function. This is another one that I really like to work up right off the bat when I see egg or sperm quality issues, because they're a key driver for cell damage. And this is about balance. It's about exposure to things that cause oxidative stress, toxins, smoking, lack of sleep, lack of stress, too much stress, And then lack of resilience in the body. Like maybe you're not so great at making glutathione and you have kind of lower reserves. So it's all about that balance there. Some of the things that I like to look at are 8-OHDG levels, lipid peroxidases. That's another way to directly measure oxidative stress. You can look at the oat pyroglutamate, which can indicate low glutathione when it's high or low. And then also melatonin can be measured. That's a critical antioxidant for fertility, believe it or not. So it's another one that I like to check out when it's on an oat panel. And then when we look at mitochondrial health, they're also critically important for cells and early embryonic development. So you can take a look at this. Again, a lot of similar markers to oxidative stress. You have to kind of, they go hand in hand. So you have to kind of look at them together. You also might think about nutrient testing for certain nutrients that are critical for mitochondria, like CoQ10. And so why is this? Why do we talk about mitochondria? Now, I always learned about mitochondria in the cardiovascular system. That's where I learned about CoQ10 and about mitochondrial health and how heart cells need so much energy. But the oocyte actually has the highest number of mitochondria and mitochondrial DNA copies of any cell. And in the male, it's the testes. It's about 200,000 copies per cell, which is 1 to 2 orders of magnitude more than our highly dependent energy. That means somatic cells like muscle. Okay. So eggs and testes require energy produced by the mitochondria. So it requires CoQ10 and a lot of other nutrients. So some of my favorite things to think about for mitochondrial support, because I'm asked this all the time, I've put on here for you. Acetyl L-carnitine is like a real rock star. You need 3 grams per day of combined carnitine and acetyl L-carnitine, but you have to have at least 1,000 of the acetyl L-carnitine. N-acetylcysteine, alpha lipoic acid, CoQ10. And I didn't put it on here, but there is some early data on like nicotinamide riboside types of ingredients. I'll make sure that we have more on that in the full seminar, because I think that's a really exciting advancement, is the use of those nutrients for fertility functions. So just to kind of summarize, I know I want to leave some time for questions. When I'm thinking about how to work patients up, of course, like when you look at everything that you could test for with fertility, it can be daunting. So you have to utilize your patient intake, your patient signs and symptoms, and kind of that whole review of symptoms to start to think about where their problem areas might be. And that's what would lead me down to further testing. So I've tried to kind of summarize that for you here, where what might I see in the patients that would key me into something like high oxidative stress or high inflammation levels? And then what testing might I run in order to try to confirm that? So again, this is like a little bit of a summary. I know we only have a little bit of time to get into it today, but I am excited to do more deep dive with you in all of these areas because there's just so much more to learn. So thank you guys so much. And I want to just leave the information on the fertility certification course. It'll be in Chicago the last weekend in September. And I couldn't believe it. I was telling Amy that I've never seen it like this, but they're doing a big special. Amy, you can talk more about that, but 40% off the course registration, which I'm going to have to share this information out because I have a lot of people who want to attend.
Yeah, definitely starting tomorrow. You can use this Memorial Day 40 code on the A4M website if you're interested in this course. As well, if you are an existing A4M customer and you have an educational advisor, give them a call in. They can work with you on registering for this course as well. We're excited. It's a 3-day course. It'll be 21 hours of CME. So, check out the website. I shared the link in the chat for all of you, but also give us a call in over the next couple of days before the long holiday weekend to discuss this course a little bit more. So, Dr. Smeaton, are you able to see the questions or do you want me to tee them up to you?
No, I can see them. So I'm happy to just go through. Yep. So recommendations for unblocking distantly blocked fallopian tubes in a patient with no history of infection or endometriosis without surgery. So it's probably the area that I feel like I have the least capability to help is blocked tubes. But one thing that can actually help is an HSG, the evaluation test that I talked about. Sometimes actually the HSG unblocks the tubes just by the nature of the fluid entering the fallopian tube and having a little bit of like osmotic pressure. It can kind of push and stretch and sometimes break apart scar tissue if it's not too serious. So you could always ask the OBGYN or reproductive endo to do that with saline only as a therapeutic approach. It's off label, but I have seen it done for patients and I've seen it be successful, which is kind of cool. Okay. The best time to test LH. So I'm guessing it's female. We're talking about when in a cycle to test. It kind of depends what you're trying to look at. And that's the answer for like all hormones, right? But when it comes to LH, most of the time where we want to check it, it is to look at the LH to FSH ratio to see if that patient might have PCOS. In that case, you're best off doing it on cycle day 3. What happens is that LH will then peak pre-ovulation, and that will trigger ovulation. So that might be the other time you think about testing is pre-ovulatory if your patient is anovulatory. You might be saying, okay, well, why is LH not peaking? Or is it peaking and we're missing it? And you might see that with patients because they try to use ovulation predictor kits and they like pee on the strips and pee on the strips and pee on the strips. And either they get no positives or they get day after day after day of positives, which can show you that LH is high. So, but normally if you're looking at it from a PCOS perspective, you'd want to check it with FSH on cycle day 3. Okay, recommendations for a patient with PCOS, but low DHEA and testosterone. Yeah, so we see this all the time. So PCOS has like several different appearances. Not always is it high androgens. That's very often the case, but not always. And so you want to think about, like, I call it the 3 things of 3 bottoms of a stool, like a 3-pointed stool. You have the pancreatic function, ovarian function, and adrenal function. So, if DHEA is low and testosterone is low, you might actually have a patient that has HPA axis dysfunction because DHEA will be made by the adrenal glands and about the same, production as cortisol. So that might be part of their dysregulation. You might need to work to help that. But I would also take a look at pancreatic function because they might have more of a metabolic type of PCOS where tighter blood sugar regulation will actually help their reproductive hormones come into better balance. Okay. What level of prolactin do you recommend treating? And do you treat with cabergoline? So I don't typically treat with pharmaceuticals for prolactin. Although, we have used the bromocriptine, but I would say generally, like if it's above 30, you're going to probably have to treat it. It's really when it's impairing the cycle. So that might vary in values for the female, but I've seen it even at pretty low levels have an impact and you might need to treat it. There are also herbal medicines that can bring down prolactin. Vitex is one of them actually, which can raise or lower depending upon dosing. So I use a lot of botanicals with prolactin, but you certainly could utilize medications as well if needed. Okay. How do you treat a euthyroid patient with increased thyroid antibodies? That's a great question. So in this case, it's not thyroid dysfunction that's leading to infertility. The thyroid hormone values are fine. Thyroid dysfunction will cause infertility. So it is something that you want to get in a tight range. But what causes this, they believe, and the data is not totally clear on this, but we do know that there are autoimmune reactions that happen within a woman's reproductive tract. They don't have a name yet, like lupus or rheumatoid arthritis or anything like that, other than in cases of antiphospholipid antibody syndrome, which is a cause of recurrent miscarriage. But what we see is that with women with elevated thyroid antibodies, there's some kind of cross-reactivity with either uterine or ovarian autoimmunity. So that's believed to be the mechanism of action there. So how do you treat it? I would treat the same way I approach autoimmunity in general, which is really trying to bring inflammation down, figure out where it's coming from. So sometimes there can be a trigger infection or a lingering infection that's causing inflammation there. And then we always look at gut health because certainly the gut microbiome and the integrity of the gut wall can strongly influence healing away from autoimmunity. Okay. At what point do you consider endometriosis as a cause? And how do you assess for that? So the assessments through laparoscopy for endometriosis right now, although there is some cool data coming out on the microbiome, believe it or not, that specific microbiome patterns are like very diagnostic for endometriosis. So you might see something come into the clinical world out of the research world in the next couple of years. But, it's tough. I don't do laparoscopy. I'm not an OBGYN. So I don't spend a lot of time in uteruses like that. But when women have like stage 2 or beyond, that's when we really worry. And sometimes laparoscopy is needed therapeutically, and then you have to work to get them pregnant pretty quickly. I've even had women where if it's severe, they will have laparoscopy, go on oral contraceptives, which can help prevent regrowth while we do a preconception protocol and get everything else right, then get them off the OCP and start to try at that point. So it can get a little bit complicated. I have given a webinar on fertility and endometriosis. So I can share the resources of that. If you want to send me an email, I can probably find a replay link for you. What do you think about peptide therapy? So I have not been trained on peptide therapy. I would love to, but I don't have an answer for you on that. I know a lot of practitioners who've been utilizing it for a wide variety. I wouldn't be surprised if there's benefits for fertility as well, but it's not within my training right now.
Yeah, I'll just jump in there real quick. If I'll send out to this group, we do have a case study that's on the International Peptide Society that was on fertility and using Kisspeptin, that there was a success in getting the patient pregnant. So I can share that out with everybody who's on the webinar this evening.
Great. Thank you, Amy. Okay, with the supplements you recommend for fertility, is it okay for women to stay on once they've conceived? It really depends upon what supplements you have people on. Generally, I'm very conservative in pregnancy. So without a reason that they need to stay on it, I would basically have them on a really good prenatal and a fish oil and a probiotic. And otherwise, I tend to stop things. If there's been hormonal support, you can't just stop it. You might have to taper it down over the first trimester. But generally, I try to be as conservative as possible. That being said, let's say that patient has HPA axis dysfunction and you've treated that with botanicals and stuff like that, or maybe they're riddled with anxiety and you've been able to manage that through natural medicine or integrative approaches. I think that it's just really important to have kind of full disclosure conversations with the patient to allow them to make informed consent. Oftentimes, my patients choose to stay on the integrative therapies, even though there's no research or, safety data, safety trials on those, because the medication options have also not been tested in pregnancy and shown to be safe. But I tend to eliminate as much as I can to simplify once women conceive. And then we kind of add on as needed basis. Okay. Do you check TMAO levels prior to recommending L-carnitine? So I don't. You certainly could, because there's a subset of patients where carnitine can be harmful. We are using lower doses, so I'm not so concerned at those levels, but you certainly could check that if you were concerned. Okay. Do we have time to keep going on questions? I know there's a few more, and more have come in as we
can keep going a little bit longer.
Okay, great.
If you're okay.
Yes. Okay, what if you find issues with HPA axis, gut, and mitochondria? In what sequence do you treat them, or do you treat all at the same time? So that's a great question. And you probably, if you're in integrative medicine or functional medicine, you know that many patients are very complex. So it's going to depend on the specific patient. It might depend on what they're suffering with. Let's say a patient comes in for fertility, but they also are hugely constipated, and that's their other kind of chief complaint. I'd always look to try to also address their chief complaints first so that they feel better, which makes it easier to make great decisions about lifestyle things when you're feeling better. And the other piece of it is tolerance for change, tolerance for supplements. Some of my patients are literally just give me everything. I will do all the things, whatever you tell me, I'll do it. And they're very compliant. Where other patients, you have to take a slower approach because they won't swallow that many capsules, or maybe they're just very sensitive and they tend to react to supplements. So it really would vary patient to patient, but there's not a reason why you couldn't do more. But I think if you had to choose, pretty much always want to start with the gut, because everything gets easier to fix when the gut's working well. Okay, any recommendations for optimal cervical mucus? So kind of two things there. One is hydration, And the other one is estrogen support. So those two things are really critical to make optimal cervical mucus. So those are the things that I typically am screening for with hydration and then working on cycle balancing. A lot of herbs can be really helpful. Shatavari is one that I like that helps with having more cervical mucus. That's actually an Ayurvedic herb, but I found that to be really effective. And for women who really aren't making a lot, maybe they're older and their estrogen levels just aren't coming up as high, there are great lubricants available that are for fertility specifically that mimic cervical mucus. And so if a woman has any struggles with her mucus, we're always working at a root cause, but I also will give them that to utilize during the fertile window because it can improve the chances of conception. Okay. Someone just asked about resharing my contact info slide. So I'll put that up here for you guys while I answer the rest of the questions. Okay. How to work up really short periods, normal 28-day cycle, but only bleeding 1 to 2 days. So I generally think about that as being the lining is not thickening very well. So that typically is due to low estrogen or a combination of low estrogen and low progesterone. So really you have to work in the first half of the cycle to get that really growing. The other thing that could be going on with patients that don't really thicken the lining of the uterus is poor blood flow. So I would be looking for signs of that too, like Raynaud's phenomenon or, like really cold all the time, thinking about how can we improve blood flow. And I really like a lot of the nitric oxide products. I don't know if I can talk about specific products in here, Amy, but
you're fine. Go ahead.
Okay. So I like the Berkeley Life nitric oxide. I think it's called nitric oxide support. It's like the only thing they make. So Berkeley Life, they usually come to the A4M conferences, but they have a really nice like nitrate based product that can help sustain nitric oxide levels higher for about 6 hours. So it's been more effective for me. I've seen big impacts in my clinic for a lot of the things that require good blood flow, like implantation, thickening of the lining, et cetera. Okay. Let's see. Fertility. Can you talk about fertility and insulin resistance? So these are definitely intricately related. I'd mentioned before, blood sugar balance is really important in order to have proper fertility. There's so many aspects to it, but bottom line is that our cells need energy to function properly. And when we have too much sugar around, especially when there's a lot of oxidative stress, we can get cell damage. So you really do need to make sure that blood sugar is well regulated. And this actually was covered. I went to a seminar in Toronto last week and I'm trying to think of the doc's name. All she does, I think it was Zeynep Uraz. But she has been doing work specifically on metabolic health and fertility in her clinic, which is a research clinic, and their outcomes were unbelievable, utilizing just CGMs. So it was not using like semaglutide or even metformin. All it was giving patients CGMs and teaching them how to read it and like get more informed feedback about their food. And the patients that were trying to conceive that were on a CGM had like massive improvements in pregnancy rates. So I'm going to have to get some of that data from her so I can include it, because I do think that one, we know it's really important, but the next step is like, how do you actually counsel patients on it, or how do you help them improve it? So I loved the CGM approach because it was non-medication. And I thought that was really unique as a teaching tool, and also setting that patient up to be healthy throughout pregnancy, to lower the risk of things like preeclampsia and having blood sugar, some glycemic dysregulation in pregnancy. And then of course, in raising their kids, making healthier food choices. So I like that kind of holistic approach. Okay. Can you give an example of biphasic herbs for follicular and luteal? That's like a big one. I would say come to the seminar. We'll cover those in depth. But some of the biggies, like for progesterone support, I really like Vitex, and wild yam is another one. On the follicular phase, things like red clover, black cohosh, a lot of herbs that can support estrogen. Fenugreek is another one there. Okay. Do you ever refer to certified fertility educators that teach mucus only, or symptothermal methods, or is FemTech your go-to? So I actually generally teach the symptothermal method. And I love fertility educators that can teach that. I really think that teaching women to understand their bodies is something that we should be doing for teenagers and preteens. I think it's a massive gap in our education. And that's just from having worked in women's health for so long. I mean, I had a patient came in who was in her early 50s, and she came to see me when I was in my general family practice, women's health focus, because she was getting all these chronic yeast infections. And so she came in when she was having one of these yeast infections, and she told me all about it. It happens like almost every cycle. And then when she got on the table and we did the evaluation, it was fertile mucus that she had been seeing. But for decades, she'd been treating with, antifungal suppositories, over-the-counter suppositories that were completely unnecessary because she thought there was something wrong with her. And I just think we do women a disservice by not helping them understand their fertile window. So I am really a big proponent of knowing your body and teaching that. The femtech approaches are great for my type A women who just won't take the time to do that. But I do think that, those do temperature monitoring. They can't monitor cervical mucus, and cervical mucus is a much better marker. So we can spend more time talking about that. But definitely am a big fan of getting to know your body and your body signs and symptoms. Okay, I know we're kind of getting over on time and the questions are not stopping. So I think we probably should wrap, Amy, and then capture all the extra questions. And we'll make sure that we cover a lot of these in our 3-day seminar, where we're going to have lots more and a whole panel of experts with different backgrounds who can answer these for you.
Yep. Love it. Great information tonight, Dr. Smeaton. Thank you so much for being with us tonight. I think this was great. Again, everybody, if you've got any questions about our fertility certification, give us a call in at A4M. And I'll wish everybody a great night. Thanks, everyone.